secondary swelling in the knee. She's tried oral anti-inflammatory. She's been on a good program of articular and muscular strengthening, but she's failed to be able to rehabilitate the knee. And what we'll do today is we'll inject 40 milligrams of depomedrol and 4 cc's of xylocaine into the knee. If she has mostly an inflammatory response, which is what is indicated on her MRI, that should help. And if she has recurrence, we'll follow it up with a series of Synvis injections. Now, there's some controversy right now, but she is in the age group, activity group, and chondral surface group that was done in the original study. So I think she's in that subgroup of patients that should be helped by the series of 3 Synvis injections. Today we'll inject into the superior medial pole, above the superior medial pole of the patella, because that's where the suprapatellar pouch is, and that's an area where we can most probably get into the joint without causing too much secondary pain. So here's the superior medial pole of the patella, so we'll outline the patella here. And what I like to do is I like to go 1 finger breath up and slightly over. That brings us through the vastus medialis obliquus, but what I've found through the years is that this is a less painful location than coming in laterally through the IT band. But if there's an effusion with synovitis where it's been chronic, then this is a better port because you can find yourself in the joint without being so much in the synovium. But in her case, where she has a slight effusion and not much synovitis, then this is a preferable location for injection because it doesn't hurt as much. As you'll have seen on the videotapes taken from the arthroscopy, coming in here at the anterior fat pad or here at the lateral location, or has been suggested mid-medial or mid-lateral, these are areas where there's very dense collagenous tissue that's very painful to go through. Here you're going through a fat pad, and the structure as you go through here that you run into is the anterior cruciate ligament, which is also very painful. So by having done many arthroscopies, I've found that the area that I can consistently see in the arthroscope being in an area that I can put a needle in reproducibly without much pain is in this area right here. So that's where I go now. All right, here we are again prepping the knee using a circular motion, and again doing it while you're ready to do the injection. And then I use the off finger here to palpate, see again where I am, and then the ethyl chloride spray.
Here's the code.
And then we go right in here and feel a second pop, and then you just inject, and it should flow in freely, and the patient shouldn't feel a great deal, although sometimes when it's quite synovitic, it'll be there. Okay, that's enough. Okay, so that's injected, and then I have a series of instructions that I give to kind of give them some idea of what they can expect. And what I tell the patient is that this is a shot of cortisone, but it comes in a crystalline form, and sometimes the body mistakes the crystals as gout crystals, and you'll get what's called a flare reaction, which means it'll be real sore tonight about 2 in the morning. It'll last till about noon tomorrow, and then it'll be better. So we're going to give you a small number of pain tablets. Make sure you get them because you want to have them at home rather than driving around at 2 in the morning and finding them. 99 times out of 100, you're not going to feel anything. It's just going to get better in a day or two. And at 2 weeks, it's usually working maximally, and the medicine will stay in the joint for anywhere from 2 to 4 months. And so I'm going to see you back about 4 to 5 months. If you have trouble before that, call the nurse and let her know that you need to be re-seen, and we'll start you on the Synvis injections. Okay? That's good.